Hello students. So let us discuss emergency medicine. Now, what are the scenarios in emergency medicine? There are different scenarios in emergency medicine which we need to have an approach, an initial approach before final disposition of the patient to particular unit, particular faculty, particular department. So in emergency medicine, whenever you receive a patient, what should be our focus? Our focus is to stabilize, to triage, and then to dispose the patient wherever the patient needs to go, right? So in emergency medicine, you need to have a knowledge of various medical emergencies, various surgical emergencies. You need to have knowledge how to approach a patient, right? So let us assume I receive a patient in emergency department. Whenever a patient comes in emergency department, right, I don't know, like patient has come to us. I don't know exact with what problem the patient will come. The patient which comes to the emergency department is different from inpatient and outpatients. Actually, whenever I have a urological problem, I go to urological OPD. But here in emergency department, the doctor is not knowing that patient is coming for a urological problem. The patient is not knowing that exactly why he is going to the emergency department. He just thinks that he has some major problem and he needs to go to some doctor. So we receive a different kind of patient. We have an unfamiliar environment. Patient goes into unfamiliar environment. The doctor does not exactly know what kind of patient he is receiving. There is a huge influx of the patients, right? So it's different from inpatient and outpatient, right? The patient only knows one thing, that he has gone because he needs an urgent medical intervention, right? So how do I approach this patient? I don't know exactly what the patient has a problem, right? So how do I approach this patient? So problem with emergency physician, they have a time restraint, they have a time constraint. In let's say less time, they have to see a lot of patients. They have limited resources, and they have seamlessly long queue of patients waiting for them. One after another, they have to, see the patients. So they have a long queue of patients. Now they have limited resources, limited time, etc. So the first thing which we need to do in emergency department is that triage. Whenever a patient comes to the emergency department, either a doctor or there is a nurse which is called triage nurse. According to the patient's chief complaint, vital signs, very important vital signs, past medical history, past surgical history, medications, allergy, brief history of present illness, etc. is recorded, right? Patient's chief complaint is recorded, patient's vital signs are recorded, past medical history, past surgical history, and medication list, patient is on what medication, right? Then if patient has any allergy, right, brief history of present illness is recorded. And according to these informations, right, it is decision of the triage doctor or triage nurse to triage the patient in particular coding, right? We triage the patient in a particular coding according to the urgent requirement of the patient, urgent need of the patient. So there is 4 code which we have to remember. The most common triage coding system practiced is emergency severity index. A patient has come to the emergency department. How severe is his need to go to the attending doctor? How severe is his complaint and how fast he needs to receive the services? According to this, there is a color coding triaging done. So there are 5 triage. Red, 1 that is critical. Patient is critically ill, and if immediately patient is not given the attention, patient will definitely expire, definitely die. So the maximum focus of the doctors in emergency department is on red patient who has been triaged as red. maybe one or two or multiple doctors are required for the red patients. Then we have orange, that is emergent. Patient is not critical, patient will give us little time, right? Patient is not critical, but patient is emergency. We have to emergently see the patient and understand his needs, understand his emergent requirement. Then we have yellow, that is urgent, not emergent, but yellow is urgent. Patient can wait but needs a urgent medical treatment or urgent surgical treatment, whatever, according to his symptom. Then green, that is the fourth triaging color, that is patient has minor problem, right? Patient can wait. And blue, that is very minor problem. Maybe if I have a lot of other patients, the blue and green patient can wait till I am attending the other patient. This is very important in mass casualty, etc. If all of a sudden we get 50 patient or 60 patient in emergency department and we have only 10 doctors present there, triaging is very important to save the lives of the patient. So according to the triage, patients are attended by the doctors. So this is very important. Now, first step one of an undifferentiated patient. I have a patient, I don't know what is his problem. So what is the step one? What will I do? Right. Initial action and primary survey, right? Always an emergency department, remember, the steps are same. Whether a patient has come with an abdominal pain, or patient has come with a chest pain, or patient is in shock, right? Abdominal pain is not an emergent or a critical problem. Chest pain may be urgent or emergent, right? Critically ill patient in cardiac arrest. You're getting my point? Whichever patient I am getting, urgent, emergent, critical patient, approach in emergency department is always same, and that is A, B, C, right? A stands for airway, B stands for breathing, and C stands for circulation. So in initial action and primary survey, we always have to focus on A, B, C. So whenever I get a patient, the first thing which I will do, I will ask his name. Yes, what is your name? Is patient able to speak? If my patient is able to speak, definitely he can maintain his airway. Patient can maintain his airway. Is his voice normal, or patient is taking a lot of effort to speak? Right? I will try to notice this, trying to see how much effort patient is taking to speak. And when I am seeing my patient, right, I am trying to locate or find a thing which can cause an immediate threat on the airway. Like patient has a maxillofacial injury, right? The fracture is unstable. There is an imminent threat to the airway. Patient has acute epiglottitis, acute upper airway obstruction. Patient is able to speak. At present, he is able to maintain his airway, but patient can go into airway compromised state. Patient's airway can, in near immediate future, can get compromised. So whenever I am assessing the airway, I have to see two things. At present, patient is able to maintain his airway or not, right? If he is at present able to maintain his airway, fine. Is there is an imminent threat in near future that his airway would get compromised? We have to see that also. Like for example, burn patient. When I am seeing the burn patient, at present he is able to maintain the airway, but on the pretext of his injury, he may go into airway compromise little later. So maybe I have to secure his airway at present only. Got it? So we have to always take care of the airway, that whether patient's airway is compromised or not, or in near future his airway can get compromised or not. Then after airway, B, that is breathing. Again, very important. Patient can maintain his airway but cannot generate an adequate tidal volume, or his effort is very high, he is tachypneic, he is using his accessory muscle, his respiratory effort is very high to sustain for a long period of time. He is breathing at present heavily. He is in imminent respiratory arrest because of the labored breathing. So is he able to breathe? Right? Is he able to breathe normally, or he is breathing rapidly? First thing we see, what is the rate of breathing? Then, is patient taking any more than normal effort in breathing? That is, we are trying to hear any noise patient is making during breathing, like wheeze, grunt, right? Abnormal breathing pattern, right? Then definitely, whenever we are doing primary survey, one monitor we always attach is pulse oximetry, by which we get the oxygen saturation of the patient. So is the effort of the patient enough to maintain his oxygenation? Is his vital organs getting adequate amount of oxygen? So important that is he breathing efficiently to maintain the oxygenation or not? So his effort, his respiratory rate, his pattern of breathing, use of accessory muscles in breathing, and is the breathing adequate or not is what we have to assess. Okay, then once airway and breathing has been taken care of, third thing is circulation. I feel for the pulse of the patient, right? We try to feel for the pulse of the patient. We always first, in a conscious patient, try to palpate the radial pulse. In unresponsive patient, remember, in cardiac arrest, we never go with radial pulse, we go with carotid. But in a responsive, conscious patient, we go with radial pulse. If I am unable to feel the radial pulse, then I go for the central pulses like carotid or femoral, right? So what all we see? We try to see the pulse rate of the patient. What is the rate? Then what is the pulse, is whether regular or not, or irregular? What is the volume of the pulse, right? And we try to see the other signs of circulatory failure, like peripheral cyanosis, mottled, like patient skin color, patient blood pressure cuff is immediately attached. So we have to see the pulse, we have to see the pulse, we have to see the rate of the pulse, we have to see the volume of the pulse, we have to see the regular or irregular pulses, whether pulse is regular or irregular. We have to look for the signs of poor perfusions like skin color, change in skin color of the patient, and definitely NIBP cuff is attached, and we measure the blood pressure of the patient. Now, this is very important in emergency department, that when you are doing a assessment primary survey, once airway and breathing has been taken care of and you're handling the circulation part, right? This is a very good time to look for the vascular access of the patient. If patient is in imminent circulatory failure, or we need, or even if he's not in imminent circulatory failure, we always need to have a vascular access. So we look for the vascular access. Does this patient already has a vascular access? Well, is that vascular access patent? If patient doesn't have a vascular access, he has immediately come from his home, right? Definitely we need to assess, secure a vascular access. So next important thing is we have to see that we can secure a vascular access or not, and if it is required, we put a large bore cannula. Like if patient is in shock or something like that, immediately we try to put the large bore cannula, right? If patient is in shock, definitely 16 gauge or 14 gauge cannula is preferred one. Otherwise 20 gauge or 18 gauge cannula is enough. So I have done a primary survey of the patient. I have done an initial stabilization. Remember, A, B, C: airway, breathing, circulation. Look, listen, feel. Right? We look the patient, we listen to the patient, and we feel for the pulses, etc. of the patient. So look, listen, feel. Right? Okay. If this was what I talked about, a responsive patient. If my patient is unresponsive, then it is not ABC. As in very detail I have talked in the cardiovascular emergencies. If I have an unresponsive patient, immediately I go for CAB, that is circulation, airway, breathing. That is, we go for all the steps of ACLS, advanced cardiac life support. We start with chest compression, right? So that is in detail discussed in our video on cardiovascular emergencies for unstable, unresponsive, pulseless patient, right? Okay. So in primary survey, we do a initial primary survey and initial stabilization of ABC, and side by side we go on taking, if my patient can give with patient, or if patient cannot give, then from the other person who has brought the patient, right, we try to take a ample history, ample history. Try to remember it in a sequence in the form of ample, AMPLE. Now ample, A stands for allergies. You always have to know if patient is allergic to some drug or some food articles or something like that, because while giving him medications, etc., we need to give him, maybe we need to give him antibiotic, we need to give him some other drug which may cause allergy. Before pain, if I give some NSAID, patient is allergic to that, we need to have an allergy history. Then M, that is medication. Patient may be on so many medications. I need to know, I will get an idea of his past medical history. And also very important, that when I am giving a new drug, right, for management, it may interact with the drug which patient is already taking, can cause some other problem. So we always have to take his past medical history. We have to take history of his medication. Then definitely the P stands for past history, right? What is his medical or surgical history of the patient. Then L, emergency patients, they're not prepared patient. They come to you immediately, or they are brought to you immediately for some imminent problem which patient is facing, and so many other maneuvers we have to do. Maybe patient, we have to oxygenate the patient, we have to do a positive pressure ventilation, etc., etc. So if possible, we always have to have an idea of last meal consumed, so that we know what is the risk of aspiration, etc., in this patient by the maneuvers which we do. And next is events, right? What events led to the present condition? How patient has reached in this condition, right? So ample history is, A stands for allergies, M stands for medication, P stands for past medical and surgical history, L stands for last meal consumed, and E stands for events which landed the patient in emergency department. So a very quick ample history we have to take. Okay, a very quick ample history we have to take. Now based on primary survey and initial stabilization, we have to take some immediate actions which I have already discussed. Well, if patient's airway needs to be secured, I have to intubate my patient. If oxygenation is not adequate, I have to put the patient on ventilator or start ventilating my patient. I have to secure a IV line for giving IV fluids, etc., to the patient. So we need to attach IV fluids. So I take care of airway, I take care of breathing, I take care of ventilation, of circulation of the patient, right? In primary survey, if immediate something I'm seeing, I have a trauma patient and he's bleeding from some site, right, which is the cause of his circulatory failure, which may be the cause of his hypotension. So definitely we have to take care of that also, right? We have to do a hemostasis for hemorrhage. If patient is in cardiac arrest, or anytime patient goes into cardiac arrest, immediately we have to go for CPR. And if I have a patient who is comatose and I have a history that the patient is a chronic opioid abuser, or patient was with his friend, took some medication, and if I give naloxone or naltrexone, then patient will come out from that opioid, acute mental status, acute mental depression due to opioid, etc. So if I get some history and I know some immediate management can turn the situation in my favor, can kind of take the patient out of that problem, immediately I have to give. That is immediate action I have to take, right? And remember one very important thing, that we are going in the sequence of ABC, primary survey, and depending upon the primary survey, immediate actions we are taking. Until and unless we have done the primary survey, we will never go to any other thing. Primary survey has to be very stringently completed. It is not that I'm seeing that patient is bleeding from one side, I just target myself on that site and don't take care of airway and breathing of the patient. We always have to go in the sequence. We have to see the airway, intervene if required. We have to see the breathing, intervene if required. And then we have to come on circulation. So definitely we have to go in a sequence, right, before we move to the other step. Okay. Now step 2. Very important. Depending upon his primary survey and the ample history, we build up our initial differential diagnosis. We see the triage note. The triage sister has taken a history, as I talked about. She took a history of the patient, noted medications, past medical history, etc., etc. Right? I also did an ample history. The emergency physician also did an ample history, did a primary survey. If stabilization was required, stabilize the patient. Now, after that, we focus on a differential diagnosis. What is my initial differential diagnosis? For example, I have a patient who complains that I am having a very bad, severe, sudden abdominal pain, right? And patient is having a severe abdominal pain, and patient is also in a circulatory compromise. Though I am not seeing any sign of trauma, patient has abdominal pain without a history of trauma, and patient circulation is also getting compromised. This may be a case of abdominal aortic aneurysm ruptured abdominal aortic aneurysm, an emergency situation. So we have to build up an initial differential diagnosis based on the primary survey and based on the ample history of the patient. And we always have to initially focus on immediate life-threatening differential diagnosis. We have to focus on those life-threatening DDs, and we have to rule out those life-threatening DDs. Then only we can save our patient, right? So this building of the DD is started in primary survey, and gradually it is refined when more and more information we get about the patient's present event, let's say past medical history, etc., etc. So based on primary survey and informations which we take from the patient, a differential diagnosis is built up, right? For example, I have an elderly female, right, with an abdominal pain, right? She came with the abdominal pain and she looks in a very much distress. Her DD for the abdominal pain may be both abdominal and cardiovascular emergencies. Even if one has myocardial infarction, right, and inferior wall myocardial infarction, the pain can radiate to the abdominal area. She may have an epigastric pain. She may have a diffused pain. So both cardiovascular and abdominal, both things we will consider. But a young female, right, younger female with pain lower abdomen, I may have a different list of differential diagnosis. So depending upon the patient's primary survey, history, age, look, etc. of the patient, we build up a differential diagnosis, and we focus on life-threatening one more, immediate life-threatening. Then comes step 3, secondary survey, right? Always, patient is of one person who will give you the best history. So if time permits and if patient permits, Give your patient 1 or 2 uninterrupted moment to tell his present problem, right? You don't need to give more than 2 minutes. Maybe patient will provide you with information which would be helpful in building up the differential diagnosis. So I have done a primary survey, stabilized my patient, built up a list of differential diagnosis depending upon that, and then I am doing a secondary survey. Now I am letting my patient, instead of asking myself the questions, I am letting my patient supply me with information. I am doing a secondary survey, okay, and trying to build up a DD, trying to let's say delineate my DD on particular problem of the focus on the particular problem of the patient. Like for example, if patient has an abdominal pain, we take a very focused history about the character of the pain, about the onset, about the location of the pain, about the duration of the pain, about the radiation of the pain, about the exacerbating or elevating factor. Little more time I am giving. So I am giving my patient, she has come with an abdominal pain. I am giving her some time and asking her to tell me about her pain. So she's telling me about her pain, she's telling me about the character of the pain. I will try to differentiate whether it is parietal or a visceral pain, which we will more discuss in the abdominal emergencies, the abdominal pain. Then I will try to discuss how does the pain come. Was it a sudden pain, or this kind of pain she always get, a gradual pain, or pain is sudden and it is increasing in intensity, which marks the severity or which marks the urgency of the situation. So she will tell me about the onset. Then location. Location can give us good idea that which organ system we have to focus on. Then radiation. What is the duration of the pain, right? Then what are the factors which exacerbate or decreases the pain? What are the associated symptoms? Nausea, vomiting associated with the pain. More it is going towards the abdominal. So I'm trying to see the problem which patient has. I'm trying to, in secondary survey, little bit trying to focus on that problem, and I'm trying to ask my patient more questions so that I can decrease the list of DD which I have. I can focus on my differential diagnosis. I can take some things out of that list. I can bring few more DDs into that list, etc. So I'm trying to build up a more focused differential diagnosis now of the problem, right? I try to see the past medical history of the patient, past surgical history of the patient, maybe because of some past conditions she has landed up in this problem. Like patient has abdominal pain, patient already knows she has a gallstone, maybe this is acute cholecystitis pain. So I take a quick past medical, surgical, social, family history. Secondary survey is more, let's say, it takes more time than primary survey. In primary survey, initial stabilization, we are focusing more on stabilizing the patient and building up a broad DD. Now we are trying to, let's say, decrease that differential diagnosis based on our secondary survey. Okay. Then based on the secondary survey, we do a very quick, focused physical examination. So in secondary survey, we do a very focused physical examination. Patient is complaining of abdominal pain, right? Now patient is complaining of abdominal pain, we do abdominal examination, right? And we try to focus on exact problem which the patient has. What is the site, right, of that abdominal pain? Is that, like, if patient is complaining right upper quadrant pain, what are the exact DDs of that upper quadrant pain? If like pain will, if it's a pain of acute cholecystitis, does it have any associated features which will mark towards more acute cholecystitis? Or if pain is radiating, so again my DD will be more focused, right? So I do a focused physical examination. Based on secondary survey and focused physical examination, I refine my differential diagnosis. Once more, what do? I refine my differential diagnosis, right? Initial list was a broader one. Now based on some things would be out of the list, some things will be added to the list, I refine it. So things that are common but not necessarily immediately life-threatening can be included, such as following for a patient with right upper quadrant pain, abdominal pain, right? Pancreatitis, gastric mucosal diseases, bowel ileus, octoma, hepatitis, urinary tract infection, kidney stone, hernia, ovarian pathology, herpes zoster, right? So maybe when I'm getting time for the secondary survey, from the list, the life-threatening DDs can be removed, and lesser life-threatening DDs of that particular pathology can be included, right? In addition, right, we can delete a lot of things from the initial list which we have ruled out. Okay, so now my DD list is more focused. From my DD list, if patient is not in an emergent situation, emergent causes of that condition has been removed, few more less emergent causes has been added. So my differential diagnosis list has been redefined, but diagnosis is still not established. I have to establish the diagnosis. How do I establish? So step 5 is diagnostic evaluation. Depending upon the problem for which the patient has come, I will order some diagnostics. I will follow some diagnostic strategy, right? If patient is having abdominal pain which is progressively increasing, so in my list I have kept abdominal aortic aneurysm, ruptured or unruptured, whatever. So definitely I will get an investigation done to rule out that. So definitely diagnostic evaluation, depending upon the history of the patient, depending upon the physical examination of the patient, if we need to rule out some emergent conditions which can be life-threatening, I have to get that investigations done to rule out those conditions. Like as I told you, old patient with abdominal pain, I have to rule out cardiovascular emergency. So I will have to get a ECG done, if required a echo done, right? So whatever orders, investigations which we are doing should be such that which will help us in making a clinical diagnosis, right? So the tools, right, it should be the diagnostic tools which should be using should be helping us in making a final clinical diagnosis, right? Now it is extremely important, right? Any result of any test which we are doing should be important enough so that it will affect our management, right? Undue test we don't have to do. So whatever diagnostic tools which we are using for the patient to establish a diagnosis should help us in managing the patient. So it should be in our mind that if I get a ECG done and if I see a ST depression or ST elevation, some problem in ECG, I have to dispose my patient to the cardiovascular, to the cardiology, right? If I get an investigation, a CT done, CCT done, right? Abdominal CT done, not CCT, abdominal CT done, and I can see the abdominal aortic aneurysm. You're getting my point? I have to dispose my patient to vascular surgeon. You're getting my point? So the diagnostic tool which we are helping should help us in establishing the diagnosis and disposing the patient, right? Disposition is very important from emergency department, where exactly you have to send your patient. Okay, fine. So step 6, patient re-evaluation, very important. Anytime a non-emergent situation can change into emergent situation. So it is very important that the ABC which we have done in the primary initial stabilization and primary survey, done and now I don't have to do. It is not so. Anytime any problem happen, again I have to go to that ABC. Patient immediately starts having problem in breathing, again I will have to go to that ABC. So re-evaluation is very important. Patient has come, I saw patient airway is stable. That means 100% for next 24 hours patient's airway is stable. This is not a case. His airway can get unsettled. So always it is important to re-evaluate the things, right? It's a dynamic process. It's a dynamic environment. Patient illness often manifesting, progressing, changing while they are in emergency department. So patient has come to you, his illness can change, his illness can deteriorate, he can be stabilized, etc. So re-evaluation is very important, right? Whenever there is change in condition of the patient, right, patient should always be re-evaluated on the list of differential diagnosis which we have built. And remember that if in the list of differential diagnosis you have listed the not life-threatening DDs and patient has deteriorated, like patient is deteriorating and patient was fine, so you had cut out abdominal aortic aneurysm, but what is happening, patient is deteriorating, so again you will add that in the list, right? You will again add that in the list DD that you have to rule out this condition also. So has patient gone from not sick to become sick? So always we have to re-evaluate the patient. We may have to add few things, we may have to remove few things from that DD's list, okay, based on the present physical situation. So remember the dynamicity of the situation, right? Patient is a dynamic problem. Now step 7, treatment and disposition. Remember, immediate treatment in the emergency department, the emergency physician has to give, and then he has to dispose the patient. Depending upon the severity, depending upon the condition, patient may be admitted, patient may be transferred or may be discharged to home. Patient does not have some emergent problem, has a mild abdominal pain, has come to you, patient is stable. Patient can be attached to OPD on, maybe you had done some investigation, a quick ultrasound you had done, but doesn't look any abdominal pathology, right? Maybe patient should be referred to the doctor on OPD basis. Patient does not require to be admitted, right? So patient can be discharged. Now, if the condition is that patient needs to be admitted, then you have to decide that patient needs to be admitted in which department, where patient has to be disposed. So patient has to be admitted and transferred to the concerned department. Okay, so treatment and disposition is very important. Now sometimes it is very easy to admit the patient. Patient looks very sick, needs acute medical or surgical attention. Now it is very difficult to make a decision in patients on those setups where you may not have certain facilities, like patient is having chest pain and you don't have a cardiovascular cath lab and cardiovascular facility at your hospital. So you need to, let's say, shift the patient, you need to transfer the patient as the condition indicate. So it is always important that whenever someone works in emergency department, he should know what facilities are available in his hospital, and for the concerned problem, what is the nearest available hospitals, definitely to dispose our patient to that particular place, because time is very important. If a patient is ill, needs the immediate cardiac intervention, each patient should be referred to the centers with cath lab available. So the emergency physician should always be aware that what facility they have in their hospital and what facilities they have to refer their patient and where they have to refer their patient, to decrease the time, to save the time, and that time can be crucial for saving the life of that particular patient. Okay, so this is how we manage any patient with undifferentiated illness has come to the emergency department, and this is the basic of management of any patient in emergency department. Now I will focus in my different videos on different systemic emergencies. I will focus on cardiovascular emergencies. I will focus on common abdominal emergencies. I will focus on pulmonary emergencies. I will focus on environmental emergencies. But the basic of all emergencies is same. A, B, C, right? Focused examination, focused history, focused investigation, a focused list of differential diagnosis. So remember, our disposition and transferring of patient or our discharge of the patient is dependent upon these things only. Okay, so this is the basic of emergency medicine. Okay, thank you.